So let's talk about MRA, MRV, trigeminal, paranasal sinus. How we scan for those. What's the A stand for in MRA?
Angiography.
What's the B stand for? Good. All right, prep is the same, so I'm not really going to go over this. So fill out the consent form. Most of these are going to be with contrast. The MRA head usually is without contrast. We use a time of flight pulse sequence, which saturates our stationary tissue, the tissue that doesn't move, so that the inflowing blood has high signal. So that one, most of the time, does not need contrast. But you can enhance the vessels a little bit more by injecting contrast. So starting IVs for these is really important. Most of these take greater than 30 minutes. Remember, give them a good time frame. Always overshoot it if you have to. Remove all the metal. Positioning is a little different. So if you're worried about a pituitary tumor, where are you putting the laser light? What's associated with the pituitary gland? The chin. Masion. Good. It goes basically directly close to you. What if you had a tumor in the IACs? Where are you going to be centering? Yeah. Try and find like a more external structure. If you have a tumor of the pons, where do you center the pons? No, try and find something that you can actually locate on the exterior. So you always want to kind of have ISO center right there because that's going to give you your best fat saturation if you do have to fat sat, and your best homogeneity. Head first supine. Remember, you can steal all these slides for your presentation. Don't reinvent the wheel. Just copy and paste. I don't care. That's why it's there. Quadrature head coil. Immobilize. Have you guys seen it in clinic? Even if it's a patient that can hold perfectly still, we're still throwing a bunch of sponges and things on. I think I saw with Rachel yesterday, they were doing a knee. Perfectly walkie-talkie, fine patient. Put the knee coil on, and then we jammed a bunch of sponges in between the knee coil and the patient's knee, because they were pretty skinny. And then put even a sandbag on their lower leg, just to remind them not to move. Like even flexing or moving the toes sometimes creates movement on the knee. So your sponges are your best friends in MRI. Just reminds them, hey, don't move, because they'll run up against it and they'll go, oh wait, I remember, I gotta be completely still. So laser light at the Masion, that's just a general one, but if you need to get a little more specific, do that. And make sure you don't blind them with that laser light. All right, so MRA. So indication, aneurysm, stroke, vasospasm. What's a vasospasm? What's a spasm just in general? It's sudden, right? So it's considered a sudden constriction of the blood vessel, reducing its diameter and flow rate. Vasculitis, so inflammation of the vessel. Then you have either any of the circle of Willis occlusion or stenosis. So occlusion is just complete blockage, right? Stenosis is narrowing. You have your basal artery. What forms the basal artery? What two arteries? They're posterior. It's not your carotid arteries, it's what's posterior to the carotid arteries. Blood flow to the back of the head. Vertebral arteries. Flow up and they produce your basilar artery. Arteriovenous malformation. We'll talk about what those are. Atherosclerotic disease. It's buildup of plaque inside the arteries. This plaque can be made up of fat, cholesterol, calcium, or any other substance in the blood. Most of the time it is your fat and cholesterol. All right, so our time of flight sequence, this is where we're going to be incorporating that saturation. Remember, saturation is pushing our vector past 90. Partial saturation is between 90 and 180. Full saturation is 180, right? So our stationary tissues are going to be saturated because we're going to give them repeated RF pulses. So we're just going to be hitting our saturated, or our stationary tissue, so the brain tissue, the white matter, the gray matter, the brain stem, all these structures are going to be hit with repeated RF pulses so that that blood that's coming from the carotid arteries is going to be fresh. That inflowing blood is going to come into this field of view and look bright on our image because it hasn't been delivered those repeated RF pulses. So it's not going to be saturated. The one we run is always a 3D time of flight because we have vessels going in all different directions, so we want to be able to visualize those blood flows and all those curves and contortions and all the vessels. So it has to be a 3D time of flight, not a 2D, so make sure to highlight that. 3D, meaning our voxels are very small, and usually they're isotropic, or close to it. So we can get really thin slice thickness. So once again, our stationary tissue is saturated here in red. Then you have the inflowing blood that hasn't had those repeated RF pulses, and it's going to appear bright on our image. So everything that's dark is just basically brain tissue. And then you have like the orbits and the sinuses. All those things are locked in. They're not moving. The only thing that's moving within this area is the new blood that's coming up into the brain. So that's why our vessels and our circle of Willis, anterior and posterior, are going to appear bright. You have a bunch of images that are from inferior to superior, and then it creates this one image, an axial image called a collapsed image. So this is a collapsed image of our 3D time of flight circle of Willis. And from that collapsed image, we can nip it where we can rotate it in any direction, and then we could actually segment out certain portions. So when you see the technologist segmenting out the anterior from the posterior, that's what we call segmenting out. Oh, let's do a thinner. Segmenting out the anterior from the posterior. Nipping is basically maximum intensity pixel where we can rotate it in any direction, but when they actually cut, that's called segmenting. So this is usually the first thing they do is separate the anterior from the posterior. Has anybody done this yet?
Yeah.
I've seen them do it.
I did one yesterday.
And then what they do is just, you can either erase outside the area that you created or keep the area inside that you created. And then you rotate it and try and just get rid of all the extra stationary tissue so you can really see that posterior circle of Willis in very good detail. So once again, this is the collapsed image. You create a nip, which is maximum intensity pixel, and then you segment out different parts of the circle of Willis. Segment. So your vessels can be enhanced even a little bit more. And typically this whole sequence is not gadolinium enhanced, but you can actually enhance it a little bit more, and you'll be able to see some of even the further out vessels. And that's just because our gadolinium reduces our relaxation rate for our flowing blood, and it appears even brighter. So image A on the left is not enhanced with gadolinium. Image B on the right is enhanced with gadolinium. Obviously, if we increase our field strength, we're going to get even better visualization of those vessels. Look at how we can really see the vessels that are further out from the circle of Willis. So if there was a small aneurysm here, we might be able to visualize it on the 3T versus the 1.5. Look at how it also saturates out the stationary tissue a lot better too. Here we're starting to see some of that retroorbital fat, and sometimes that overlays some pathology that we need to see. So it's always better to scan with contrast at a higher strength magnet and with what we call magnetic transfer code. Here's your Mra Henry Protocol. It's really only one sequence, so it's very fast. This is usually incorporated into our stroke protocol. Has anybody seen a stroke protocol yet? So there's 3 things that you always include in a stroke protocol. MRA head's one of them. What do you think the other ones are? MRI brain with and without contrast. And MRA neck with and without contrast. So we always want to visualize the carotids, the circle of Willis, and then the brain to see if there's any type of stenosis or occlusion or aneurysm.
What was it, the one for the neck?
MRA neck with and without contrast. So those are always the 3 exams we run for a stroke protocol. So you're going to see a lot of those, especially if you work second shift. Usually, like from the ER, your inpatients, you're going to get a lot of those. You do all 3 of them. So get used to that. And this is where, as a beginning student, you can set up, say, the MRA head, but then have the technologist show you how to do the MRA neck. But get involved on some of these. You can do the brain and the head, and then maybe have the technologist take over for the neck. All right, coverage. We need to cover from slightly above the corpus callosum. We're still angling with the corpus callosum down to at least the foramen magnum. So that's where the circle of Willis really is. So the vertebral arteries and the carotid arteries kind of end here, and then it starts to create the anterior and posterior circle of Willis. We put a saturation band. Who here's added and taken away saturation bands on their console? So anytime you add a saturation band, have you seen the images after? Doesn't it look dark where that saturation band was? That's the point. So we are basically saturating any tissue that's behind it. And in this case, we are not concerned with venous blood flow, so we put the saturation band above. So we have arterial blood flow coming from the carotids, and then we image the circle of Willis, but we do not want that superior sagittal sinus or any of that blood flow from the venous structures coming back down into our image. So we put a saturation band up there to prevent that. And then we could add magnetization, transfer contrast. This further suppresses our stationary background tissue. This is just something you can select on your console. So these images here are what we call our source images. So you can see here how everything is being suppressed, stationary tissue, and then you have your vessels. And basically, you put all these stacks of images on top of each other, and then your collapsed image creates one where you can see all the vessels. Here are your parameters for these. So we have a really short TR. So do you think this is a spin echo or a gradient echo? It's a gradient echo. With TRs this short, we're usually getting it to a gradient echo. Our flip angle, look at our flip angle, it's only 25 degrees. Remember, our spin echo, we want 90, right? Slice thickness, really thin, less than 1 millimeter. Field of view covering the entire brain and our phase right to left. So what does maximum intensity projection mean? So this is the most commonly used post-processing technique. So what are the 2 main things if you work on a Siemens scanner? You usually select a certain pulse sequence that you ran, and I need to go up to my post-processing tab, right? And then usually I choose either MIP or NPR, that is the other one that you use regularly. NPR is multiplanar reconstruction, basically meaning if you acquired it sagittally, you can reformat it in the coronal and the axial. So most of those MP range brain scans that you guys have usually are coming in our sagittal, and then you reformat it in coronal and axial. So I was with Tyler yesterday, and she had filled up all her brain categories, but on every brain you do a reform NPR. So now she can put those brains under her post-processing tab on ART. So make sure you're utilizing all those brain scans to the best. Put it in a category that you can count it. So MIP is a reconstruction of a 2D projection image from 3D data by a ray tracing algorithm, which produces an image with white pixels representing the high intensity signal in that location within the examined volume. So this is repeated at different angles to create a 3D representation. So that's why we're able to rotate our circle of Willis around so that we can segment out certain areas that we do not need. So just to help you out again, if you have to do this in clinic, best way is to start right here on your axial, separate anterior from the posterior by cutting through those communicating arteries, and then say you have your sagittal view. This is a way to separate them also. Okay, it's harder from the coronal because they're kind of overlapping each other. But that's a good way to get you started. And then you spin them, and then you nod them for the radiologist. So you give them different rotations so that the radiologist can really see if there's any type of stenosis or occlusion. Know the anatomy of the circle of Willis. I guarantee this will be on the registry. So make sure you know all these vessels. I'm sure you had to do that for cross-sectional. Do you guys have to do that for cross-sectional? Know the circle of Willis? Mm-hmm. So I supplied different views. So this is your coronal, and here's your sagittal. Okay. Really highlight this slide. You're gonna know one view. Know your axial. All right, some pathology. Here's arteriovenous malformation. This is an abnormal connection between arteries and veins bypassing the capillary system. This is usually congenital. And symptoms may include headaches and seizures. So maybe your patient had an AVM here. Sees that on the table. Your patient yesterday might have had this.
Oh.
Symptoms include seizures.
Oh, yeah.
Arteriovenous malformation. I think they probably had epilepsy. Because if they knew that they had a lot of seizures, then it's usually an epileptic patient. Mycotic aneurysm. This is an infected aneurysm arising from a bacterial infection of the arterial wall. And then this could spread into a bacterial infection. So you can see it on the left side here. You see the stenosis or the occlusion, and then you see the outpouching right here. All right, MRV. So once again, we're imaging the veins, not the arteries now. So some indications are venous thrombosis. What's a thrombosis? Clot. Great. Intracranial hypertension, pseudotumor, drowsiness, confusion, accompanied by a headache. MRV, once again, it's just one pulse sequence. Typically a pretty long one, like 4 or 5 minutes, sometimes even longer. So here is your MRA specific protocol, B7. And then you could do one with and without contrast if you needed. So the imaging technique used to get MRV is what we call phase contrast MRA. This is where we are going to be changing the phase of the spins and showing the difference in phase between our stationary and our moving spins, or our flowing blood. So our stationary spins, we're going to apply, and our flowing spins, we're going to apply a bipolar gradient to really highlight the difference between the two. And you're going to get a greater phase change between the blood flow compared to the stationary tissue. The stationary tissue is actually going to be dephased and rephased so that there's no net phase, but then our moving spins are moving along our gradients, so they're going to have a larger net phase change. So that, meaning our blood flow, our venous blood flow is going to appear bright, and then once again, our stationary tissue is going to appear dark. So it's actually a better way to suppress our background tissue than our time of flight imaging. But here we're just, once again, we're applying a bipolar gradient pulse with equal magnitude in opposite direction used to diminish signal from stationary tissue. So our phase contrast, several advantages. We can actually visualize different types of blood flow. Which blood flow usually flows faster, arteries or venous blood flow?
Arteries.
Arteries, good. So usually we can actually use a different velocity encoding values. So highlight this, V, E, and what we call a VENC, just our short acronym for velocity encoding values. So we can change our VENC to highlight arteries versus veins. So we actually use a higher VENC for arteries, around 40 to 70 centimeters per second, to catch our faster blood flow. And then we crank down our VENC for our venous blood flow. So since we're trying to do an MRV, which one are we going to use? A lower VENC or a higher? If you're trying to visualize for an MRV.
High. Low.
Low. So low VENC because we want to visualize veins. So here it is. So this is a 2D pulse sequence, not a 3D. It's a sagittal. We're covering the entire brain from right to left. We put the sat band now inferior. Why is that? For the time of flight where we were looking at arteries, we put the sat band above. But now we put the sat band below. Why is that? What are we trying to saturate out? Arterial blood flow or venous blood flow? Arterial. And arterial blood flow is coming up from the carotids. So here we're more focused on venous blood flow, so we try and saturate arterial blood flow coming from below. The only downside for our phase contrast MRV, it's very long scan times. So you can visualize different blood flows by changing the VENC. You can visualize blood flow in different directions. So there are a lot of advantages to this phase contrast imaging. But the only downside is it's very long scan times, 5 or 6 minutes per pulse sequence. This is what it looks like. Here's our source images, and then once again it creates one collapsed image here. And you can see that superior sagittal sinus very well. Most of the time they're 2D, but you can actually have a 3D phase contrast, and the only downside to that is it's going to increase the time even more. Make sure to know the anatomy of all the venous structures here. Okay? Some pathology associated MRVs. Venous thrombosis. Like Tyler said, that's a blood clot that forms in the brain's venous sinus. Sometimes this prevents blood from draining out of the brain. As a result, blood cells now break and leak blood into the brain tissues, forming a hemorrhage. So here you can see that clot preventing any of the drainage of that sinus. All right, let's move on to trigeminal. So indications, trigeminal neuralgia. Sometimes this is also called tic-duraloo. French. Nerve schwannoma. Where else have you seen schwannoma? Acoustic neuroma, schwannoma. What were we scanning? IACs. If you see schwannoma, always get some slices through the IACs. Hemifacial spasm, facial pain. So remember that trigeminal nerve is the 5th cranial nerve. Remember, you need to know the cranial nerves. It's the 5th cranial nerve. and it's responsible for the sensations in the face. It's also responsible for motor functions such as biting and chewing, and it actually is the largest of the cranial nerves. So they call it trigeminal because it divides into three parts: ophthalmic nerve, maxillary nerve, and then the mandibular nerve here. You can see how this one goes a little bit more superior. Maxillary nerve goes to the maxillary sinuses, and then the mandible nerve here goes down to the mandible. So that's how it gets its name. You can see how the trigeminal, from the IAC pulse sequence, you can really see it, but it exits the pons on the lateral aspects of the pons. So that's where it first originates from. Here's your Henry Protocol. So just be mindful of the coverage that you need to get. So here, we're covering the IACs, because remember, it originates near the IACs in the pons. And then for the axials, we're covering from the frontal sinus all the way down to the mandible. Because remember, on this image here, we need to cover the frontal sinus all the way down to the mandible to get all three of these nerves. And then for coronal, we cover from the tip of the nose to the posterior arch of C1, because we need to get it all the way back to where it originates from. So the posterior arch of the C1 is right here behind the pons, where it originates from. So here's our 3D KISS or Fiesta. KISS is usually our Siemens, Fiesta is usually our GE acronym. And then this is really just to see the IACs and to see where that trigeminal originates from. Once again, it's the lateral aspects of the pons. So this is no different from your IACs, but you just get one axial 3D sequence. Very thin slices, good resolution, good signal. Here's how you set up for your thin slice coronals. 3 millimeters slice thickness. Remember, on the coronals, we're covering from the tip of the nose to the posterior arch of C1. Here's C2, so C1's right here, and then the posterior arch has to go behind the spinal cord here. So we have got the adequate coverage. And you can see here the pons. We got the entire pons, and we know it originates from the lateral aspects of the pons. We have the entire frontal sinus all the way down to the mandible. Axials, once again, above the frontal sinus all the way down to the mandible, and we got it coverage all the way anterior to posterior. You can see our phase directions right to left. Thin 3 millimeter slice thickness. Pathology, trigeminal neuralgia. This is chronic pain condition that affects the trigeminal or fifth cranial nerve. Pain associated with nerve injury or nerve lesion. Usually this is described as excruciating pain to one side of the face, which could last for a few seconds or a few minutes. So where is that lesion at, on the right or the left? Okay. What type of weighting do we have? Is our lesion highlighted? T2. I know this is post-contrast because I see contrast in the meninges. You see it right here? You see it in the sinuses right here? So I know this is post-contrast. And post-contrast usually means it's T1. So it's tough to tell because you don't really have any fluid on this particular slice of the brain. But here's the pituitary gland right here. Pituitary gland is lit up with contrast. And remember, pituitary gland always highlights contrast. So we know this is post-contrast, and typically we always run T1's post-contrast. So T1 post-contrast, and it's fat-satted because the retroorbital fat right here is nulled out. And here, the only fluid actually we can see, you see this small little bit of the orbits? The fluid within the globes of the eye. It's dark, so we know this is a T1. So T1 post-contrast lesions on the lateral surface of the pons on the left side. All right, so here's some indication for your paranasal sinuses. So we have all the different types of sinuses. So they could be anywhere. So abscess, inflammation, cellulitis. These are some of the things you're going to see. Inverted papilloma, sinus infections. Pretty much every brain scan you do, you'll see the maxillary sinuses filled with fluid, because everybody has some kind of allergy, especially during like the spring where you have pollen. You're going to have a lot of people highly congested. So don't think that's some kind of tumor or anything in the sinus. It's just fluid buildup. Here are the main sinuses. We got our frontal sinus, ethmoidal, sphenoidal, and maxillary. Maxillary is usually the one where you're going to find the most fluid. What are our sinuses for? Why do we have them? I think they're just to annoy us, to be honest.
They're what?
They're just to annoy us. No, they have a reason. It's to lighten the skull. Our skull's pretty heavy with our brain, so it's to lighten our skull, and it's to improve our voices. So, have you ever been seriously congested? Like your voice changes, goes a little more high pitch. But the main function is to produce a mucus that moisturizes the inside of the nose. This mucus layer protects the nose from pollutants, microorganisms, dust, and dirt. Here's our Henry Protocol. So once again, we need to cover from the frontal sinuses all the way down to the mandible, the maxillary side, and then we need to cover from the tip of the nose all the way back to the sphenoidal sinus. So here's our coronals. Once again, tip of the nose. We've covered the sphenoidal sinus because we know the sphenoid sinus is right below the pituitary gland or the sella turcica, so we got coverage. So that's why it's so important you guys know your cross-sectional anatomy. I don't want you guys to not add enough slices and get enough coverage to cover all these things. Here's your axials. Sometimes they angle it with the hard palate, but we're getting the frontal sinus all the way down to the mandible. Some pathology and cephalocylia. This is a congenital brain malformation, sometimes known as cranium bifidum. Neural tube defect characterized by sac-like protrusions of the brain and the membranes that cover it through openings in the skull. So you can see it right here on a pediatric patient. This is more common in South and Southeast Asian populations. Inverted papillomas are nasal tumors that originate in the mucosal membrane of the nasal cavity and the paranasal tissues. So you can see that inverted papilloma on the left side here. Papillomas are benign epithelia tumors that grow outward in finger-like projections in the nose. In inverted papillomas, these projections grow inward, and you can see the underlying bone. Keratocyst. These are benign cystic neoplasms involving the mandibular or maxillary and are believed to arise from the dental lamina. So if you see on a T2 weighted image here, if we see bright near the mandible, it could be a keratocyst. They are locally aggressive and tend to recur after it. So once they've removed it, they tend to go back. Any questions? The main things to take away from this lecture are your time of flight and your phase contrast. Make sure to study those slides. So this is where I'm mostly going to be asking about. Make sure you study the anatomy, your circle of Willis anatomy, and the cranial nerves, and also your venous structures of the brain, your superior sagittal sinus, and then your transverse sinus drains into. So make sure your dural sinus. Make sure you know all those things. Any questions?